Hello? Hello? Are you guys able to hear me? Hello?
Yes, yes.
Okay, perfect. Okay. So let me first of all share my screen. Okay. Okay, so today we are going to discuss a really important topic that is stomach along with small intestines, right? So we'll be discussing the entire pathologies and all of the hygienes, right? So we'll be discussing with our first topic that is acute gastritis, right? Acute gastritis. So what is the main idea of acute gastritis? What is acute gastritis? It's simply acidic damage to your stomach mucosa. We are already aware of the fact that stomach is an important structure which make a ton of acid, and once this acid just keeps on eroding and damage your own stomach mucosa, that condition is simply known as acute gastritis. So before diving deep into the reasons and causes that why do someone have this acidic damage, before discussing that, we must know some of the defense mechanism which protect your stomach from this acidic environment, right? So all of you are aware of the fact. We already discussed that stomach is basically lined by a mucosa, right? And that mucosa, that mucin producing mucosa is basically important for protecting your stomach from this acidic stress, right? What else is important for your protection is that we already discussed that this mucosa keeps on secreting your bicarbs, right? H2CO3, bicarbonates. So we already know whenever acid combined with bicarbs, whenever ACE combined with base, basically we are going to have formation of salt. And salt formation do not causes any damage. So this is also considered to be one of protective mechanism of your stomach, which have adopted in order to save your stomach from this acidic damage. Okay, what is our last mechanism of our protection is that the blood supply, right? So for example, if this is your stomach, right? So we already discussed that we have mucosa. This mucosa basically is like it's going to first of all provide the physical protection to your muscular layer of your stomach. Secondly, we discussed HCO3, right? HCO3 bicarbs also helps in protecting your stomach. The third mechanism is your blood supply, right? The blood supply. So how do the blood supply helps in protecting your stomach? For example, by any chance, if the acids just cross this barrier, this two protective mechanism, so what the blood vessels are going to do, it's going to trap off all of the acid. It's going to take it into the blood, whatever leaks this mechanism, right? And in this way, it's going to provide physical protection, right? So discussing these protective mechanism, now this pathology, we can just break down this pathology very easy. How? Whenever all of these three mechanisms are disrupted, in that case, we are going to see acute gastritis. Or in other words, we are going to have acidic damage of your stomach. Is that clear?
Yes.
Okay, perfect. So let's discuss different conditions which disrupt these protective mechanisms, right? The first one is going to be your severe burn. What happens in severe burn, we are already aware of the fact that severe burns lead to dehydration. Is that right? Severe burns lead to dehydration. And once an individual is severely dehydrated, he's going to have hypovolemia, right? If he's having hypovolemia, it means that now the third mechanism which we discussed, the blood supply, the blood vessels around your stomach, there's going to be less blood. If there's going to be less blood, so one of the protective mechanism is disrupted. So in this case, this individual is going to be vulnerable to acute gastritis or acidic damage. That is, whatever acids surpasses this mechanism of protection, so you do not have the third mechanism, that is your blood vessels. So in this case, this individual is going to be vulnerable to acidic damage. Is that clear?
Yes, sir.
Okay. So now you guys are going to be telling me which prostaglandin basically provide protection to your mucosa.
I2, E2.
Perfect. PG, E2, right? So I2 and E2. Okay. So for example, if an individual is on NSAIDs, so can I say that that individual is also going to be prone to acidic damage or acute gastritis?
Yes.
Perfect. So NSAID use, right? What else? What else we are going to discuss is heavy alcohol consumption, because alcohol itself is a toxin. Alcohol itself can disrupt this mucosal layer and it can cause acute gastritis, right? What else? Chemotherapy. You know what do we do in chemotherapy? We basically, the main idea of chemotherapy is to slow down the growth of highly active cells, that is cancer cells. And we know the epithelial layer are also highly, like they have high metabolism, that keeps on dividing very rapidly. So that's why an individual on chemotherapy, his mucosa layer is going to be, like remain stunted, and in that way, he is going to be vulnerable to acute gastritis. Is that clear? What else? We discuss a pathology that is increased intracranial pressure or Cushing ulcer. We are going to discuss that. So we know that we have recently discussed our entire neuro. We know whenever the intracranial pressure increases, so what happens? This is going to lead to herniation of your brain through foramen magnum, and vagus nerve is also, like passing through that foramen, so it's going to keep on irritating your vagus nerve, right? And once the vagus nerve is irritated, it's going to dump off a lot of acetylcholine, right? And we discussed on the parietal cells, which is basically responsible for production of your acid, it have 3 receptors, it have 3 stimulus for production of acid, and one of which was your acetylcholine. So can I say that increased intracranial pressure due to stimulation of vagus nerve, due to a lot of acetylcholine can also increase the quantity of acid, which can in turn, like cause gastritis, damage to your stomach? Can I say that? Acidic damage.
Yes.
Perfect, right? So these are all of the causes of acute gastritis. So acidic damage result in superficial inflammation. It can cause erosion, and further it can lead to ulcer, right? That is, all of the mucosal layer is going to be knocked off, and it's going to give us ulcer, right? So this was all about acute gastritis. So the next topic which we are going to discuss is chronic gastritis. So what is chronic gastritis? As the name indicates, again, it's a chronic inflammation of your stomach mucosa, right? It's chronic inflammation of your stomach mucosa. Okay, so this chronic inflammation can be due to 2 reasons. We are going to divide it into 2 types. One of which is chronic autoimmune gastritis, and the other one is going to be chronic H. pylori gastritis. What's the idea? Or some autoimmune diseases can cause inflammation within your stomach. Inflammatory cells are going to come into your stomach, and in that way, it's going to induce chronic inflammation. We are going to discuss it in detail in a while. What else? The H. pylori itself can cause inflammation, right? It can cause chronic inflammation due to the chronic presence of this bug. It can lead to chronic inflammation. So the first one which we are going to discuss in a little bit detail is chronic autoimmune gastritis. So what is chronic autoimmune gastritis? As the name indicates, it's an autoimmune destruction of your gastric parietal cells, right? Parietal cells. So if it's an autoimmune destruction, or it's an autoimmune inflammation or destruction of your gastric parietal cells, so can you guys tell me which kind of cells are going to be responsible for this inflammation? Let me give you a clue. It's an example of type 4 hypersensitivity. What do you guys think? Which cells are going to be responsible for the pathogenesis?
T cells.
T cells. Perfect. T cells.
Yeah.
T cells are going to cause this autoimmune inflammation of your parietal cells. So what would be the clinical feature if we have autoimmune, chronic autoimmune gastritis? First of all, due to inflammation, is going to lead to atrophy of your mucosa, right? Atrophy of your mucosa. Is that clear? Inflammation is going to lead to atrophy, right? What else? There is an important concept, but before that, discussing that concept, we are going to discuss a little bit about the normal anatomy or the normal understanding that we have about ileum, right? Okay, you guys already know we have fire patches, right? So what are fire patches? We discussed it in a great detail.
Lymph node in the stomach.
Okay, so there, can I say there are simple lymphoid tissues present within your ileum?
Yeah.
They're same as that of lymphoid, right? They have the follicles, they can make antibodies, right? They can make T cells, they're same as that of lymphoid tissues, right? Okay, so my question for you guys, as we discussed one of our pathologies that is GERD, right? In GERD, we discussed that whenever the acid is refluxing back to the lower esophagus, So due to chronic reflux, the esophagus is going to be transformed into certain epithelium, which is going to bear this stress. Can I say that? You know that, right?
Yes.
Yes.
Okay. So for example, if now we have chronic presence of the T cells within the stomach, so can I say that in order to bear these T cells, the stomach mucosa is going to be transformed into mucosa, which can bear this stress, which can bear the presence of T cells. And in my knowledge, I know that fire patches can bear that stress, right? So it's going to lead to metaplasia, right?
Hypertrophy.
Which kind of metaplasia? Intestinal metaplasia, right? And what do we mean by intestinal metaplasia? Due to the presence of these cells, these autoimmune cells, due to the chronic presence, as it's a chronic condition, right? What happens? The stomach mucosa is going to be transforming itself to certain cells which can bear this stress. And we know that are going to be your fire patches, right? Present in your intestines. So it's going to be intestinal metaplasia. Is that clear?
Yes.
Perfect, right? That's perfect. Okay, what else we are going to see? As we have chronic inflammation, the parietal cells are going to be knocked off. So we discuss physiology, right? If we have less HCl, negative feedback mechanism lost on your gastric. So would we be seeing any gastric G cells hypertrophy? Hyperplasia?
Yes.
Yeah, so these cells are going to become hyperplastic, right? Because the negative inhibition of the HCl is going to be lost. Is that clear? What else we are going to see? If you are knocking off the parietal cells, we already know that now this individual can't even produce your intrinsic factor. If he cannot produce intrinsic factor, it means there will be problem of reabsorption of your vitamin B12. And whenever we have problems with vitamin B12 reabsorption, we already know the pathologies, which associated pathology, megaloblastic anemia. You already know that, right?
Yes.
Perfect. Okay, what else? Now, if
Finish
we
it.
have, okay, perfect. Now, if we have, let's suppose, like we have chronic condition, now we have intestinal metaplasia. So the cancer which we are going to see here in this case is going to be adenocarcinoma, right? Adenocarcinoma intestinal type. Is that clear? So this was all about chronic autoimmune gastritis. Let's discuss chronic H. pylori gastritis, right? So as we discussed, H. pylori is a urease positive. It's also going to be a protease positive. It has proteases. Proteases in turn would lead to inflammation. It's going to be a chronic inflammation, basically seen at the antrum, right? So it means that H. pylori itself can cause inflammation, right? And if it's causing inflammation, we already know the features of inflammation, right? So again, we are going to have inflammatory cells there. And as a result of that, it can also induce ulceration. We already know that. Inflammation, again, is going to lead to weak mucosal defenses. And if these defenses are lost, what happens? An individual, what would be the presenting feature? Gastro, abdominal pain. Along with that, we are going to again have, okay, we already know chronic inflammation lead to increased chances of carcinoma, right? If you are chronically irritating something, you already know the concept. So it can also lead to gastric adenocarcinoma, right? So that's the entire idea of your chronic, acute and chronic inflammation. So the next topic which we are going to discuss is peptic ulcer disease, right? Peptic ulcer disease. You are already familiar with peptic ulcers. Okay, what's the most common site of peptic ulcer disease? You guys are going to be telling me.
Duodenum.
Duodenal ulcer. And in 95% of cases, again, it's going to be due to H. pylori, right? 95% of cases. Is that clear? Okay, Zollinger-Ellison syndrome. It can also increase the level of gastrin, increase HCl can further cause ulceration. We already know that as well, right? Okay. So basically we have like duodenal ulcer. So you guys are going to be telling me, for example, if I have an individual with peptic ulcer disease, that is duodenal ulcers, if this individual is consuming, like if he's taking some meals, what do you think? Will the pain be improved or worse?
It will improve.
Improve. Okay.
Better
So
with
this
food.
pain is going to be improved with meals. Okay, what's the reason for that? The reason is quite simple. For example, if this is our stomach, we have our duodenum, right? So as we take in the meal, we already know that the chyme is acidic, and once the acidic chyme enters your duodenum, so duodenum already prepare itself to decrease the acidic content of your chyme. How? the secretin is going to be released. Secretin is going to tell your pancreas to dump off some bicarbonates in order to neutralize that acid. You already know it, right? So once we are consuming the meal, the duodenum is preparing itself to neutralize your acid by by secreting a lot of bicarbs, right? So in this way, bicarbs secretion is going to help pain, right? Neutralization process. Is that clear? Okay, we discussed in anatomy in quite detail, so you guys are going to be telling me that as well. For example, we have an individual, he has peptic ulcer at the anterior part of your duodenum, right? So which artery is
Left gastric.
Perfect. Okay, left gastric? I'm talking about
Yes,
duodenum, not
God,
your...
Oh, sorry, duodenum. I thought you said anterior part of stomach.
Yes, duodenal artery, right? That's the left gastric in case of lesser curvature of your stomach, right? Gastric ulcer,
Yes.
right? Okay, perfect.
Yes.
So the gastro, duodenal
Duodenum.
artery is going to be vulnerable to bleed, right? Okay. What else? Let's discuss gastric ulcers. So we know that gastric ulcer, again, it's basically ulceration of your stomach. Again, NSAIDs can do that, and H. pylori itself can cause, right? What's the differentiating feature? With consumption of meal, will the pain be worsened or will the pain will reduce? What do you guys think?
Worsen.
Decreased.
Worse.
Well, yes, the idea is really clear. As you are consuming food, your stomach prepare itself by making more HCl, and more HCl is going to cause more pain because you have ulcers there, right? And if it's present at the lesser curvature, so now you guys are going to be telling me which artery is going to be vulnerable to bleed.
the left.
Now the left gastric.
Left gastric, you have your word MCQ on both of them, right? Left gastric artery. Perfect, right? Okay. So the differential diagnosis, basically duodenal ulcer are never malignant, right? But the gastric ulcer can become malignant, right? So let's just differentiate some of the ulcers. How do we suspect whether the ulcers are going to be benign or malignant, right? So benign peptic ulcers are basically small, that is 3 centimeters, right? They are sharply demarcated because they do not have any ability to invade. That's obvious. So we'll be having sharp demarcation, punched out lesion, right? But in case of malignant ulcers, what's the main differentiating feature is going to be large, and the margins are not going to be well demarcated. They are going to have heaped up margin, right? So for example, if you have ulcer here, the margins are going to be heaped up. They're going to be protruding outward, right? Heaping of the margin. That's really important, right? But the biopsy itself is going to give you the definitive diagnosis. Is that clear?
Yes.
Perfect. So the next topic is basically going to be relating with the same concept, that is gastric carcinoma, right? Gastric carcinoma. So what is gastric carcinoma? As the name indicates, it's a malignant cancer, right? Malignant proliferation of surface epithelial cells. And the cancer which we are going to see here is adenocarcinoma, right? We already know that. Okay. So these malignant cancer further can be classified into 2 types. One is going to be your intestinal, and other is going to be your diffuse type. So for the intestinal type, which is going to be most common one, right? Remember that it's the most common intestinal kind of type of gastric carcinoma is going to be common, right? So for the intestinal type, what would be the presentation? We are going to have irregular ulcers with heaped margin. We already know that, right? It's basically the characteristics of a malignant cancer. The margins again are going to be heaped up, right? And most commonly, it's going to arise at the lesser curvature of your antrum, which is the same location where we were seeing gastric ulcer. Is that clear?
Yes.
Okay, so antrum. And for the intestinal type, you already know that. For example, to get intestinal type of carcinoma, before that, we must be having intestinal metaplasia. We know that. That's why we are just naming it as intestinal type carcinoma, right? Okay, so for the intestinal metaplasia, we already know that we must be having chronic inflammation. That is H. pylori or autoimmune gastritis. Here we must be having T cells. So these chronic presence of T cells is first of all going to transform this mucosa into intestinal type. And once the mucosa is transformed into intestinal type, if that mucosa gets cancer, It's going to be called as intestinal type gastric carcinoma. That's simple. Is that clear? Hello? Any questions? Hello? Hello?
Yes.
Can you... Okay, perfect. So the next type of cancer is going to be diffuse type. For the diffuse type, just keep in mind, as the name indicates, we are going to have like diffuse type cancers. It's going to be diffuse, present throughout your stomach mucosa, right? But the characteristic cells, which we are going to see here in diffuse type, are going to be signet ring cells. So what are signet ring cells? They are basically characteristic like findings in your diffuse type of gastric carcinoma, right? So what happens due to the presence of the mucin content, the nucleuses are going to be pushed to the peripheries, and it's going to give you a characteristic appearance in which the nuclei are present in the periphery, and these are basically called as signet ring cells, right? And as it is a diffuse type, it means it will be present throughout your stomach wall. And due to the presence of these, you have a word MCQ on that, signet ring cells. Just remember that, okay? So, due to the presence of these signet ring cells throughout your stomach wall, the stomach is going to adapt in a certain way that it's going to lead to desmoplasia. So, what is desmoplasia? Due to presence of, like, these cells present diffusely throughout your stomach wall, the stomach wall is going to become more thick due to presence of these signet ring cells signet ring cells. And this due to the presence of signet ring cells, stomach mucosa is going to undergo thickening, and this thickening is basically called as, the term used for that is desmoplasia, right? It's also called as linitis plastica, right? That is thickening of your stomach wall. Is that clear? No?
Yes, sir.
And like, in order to get diffuse type, we do not need intestinal metaplasia. We have no association with H. pylori, simply like or nitrosamine. And the features in cancers, we already know that we are going to have weight loss, abdominal pain, and these cancer can metastasize to certain lymph nodes. One of your word MCQ. So you guys are going to be telling me that. You guys should know that, right? So, for example, to which lymph nodes these cancer cells are going to invade or they're going to spread metastasize?
Left supraclavicular.
Also known as?
Virchow nodes.
Virchow node.
Nodes, right? One of your dual MCQ. That is left supraclavicular lymph nodes. Is that clear?
Yes.
Perfect, right? So this was all about our stomach. The next topic, which we are going to discuss, is small bowel, right? So we already discussed some of the pathologies, duodenal atresia, we know Meckel's diverticulum, we know volvulus. So the pathology which we are going to discuss today is intussusception, right? So you guys are going to be telling me what is intussusception.
It's telescoping.
Yes, perfect.
Distal.
Let me just give you a simple idea, right? Okay, perfect. So it's basically telescoping of the proximal portion of your small bowel into the distal. What do I mean by that? For example, if normally the food is flowing like that, right? So what happens, for example, if we have, let's suppose some hurdles present here, right? So with the movement of that food, what happens? It would just pull off this area of your small bowel forward into the distal portion, right? This is going to be your distal portion, and this is going to be your proximal portion. So with the movement of food, if you get some hurdles, let's suppose we'll be discussing what are those hurdles, right? So what happens as the food is moving, it would just telescope the proximal area into distal, and this way it can cause obstruction, right? It can disrupt the blood supply as well. It can cause infection. So intussusception basically is telescoping of proximal segment of bowel into a distal segment. That's simple, right? How do we get that telescoping? As we discussed, if we are going to have some hurdles or obstruction. So what are the type of hurdles which we are discussing? It can be due to lymphoid hyperplasia. For example, if you have lymphoid tissue present, for example, let's take an example of child, right? For example, if this child is having any viral infection, what happens? The viral infections, T cells, paracortical area T cells are going to become hypertrophied, and as a result of that, we are going to have lymphadenopathy. Lymph nodes are going to be enlarged. We have lymph node present within the small bowel as well in the ileum. So due to enlargement of these lymph nodes, now it's going to be as a hurdle present within the movement of food particles, right, or the food substance. Is that clear? Hello?
Yes, yes, clear.
So viral infection, lymphoid hyperplasia. Now, as the content of your stomach is moving, it's going to pull the proximal portion to the distal portion, giving us intussusception, right? And this intussusception, okay, it can be due to tumor as well. For example, if you have a big tumor growing on here, again, it can be as a hurdle. The content, the food content, which is moving through your small intestine, it can again pull the proximal portion into the distal portion. Is that clear? And if we have this condition, the blood supply to this area can be disrupted, which can again lead to a lot of problems, that is infarction and things, right? Current jelly stool, remember? One of the feature of intussusception as well, right?
Yes, sir.
Okay, perfect. So let's discuss our next pathology, that is going to be lactose intolerance, right? So the idea is really simple. Lactose intolerance. What do we mean by lactose intolerance? As the name indicates, individual is going to be intolerant to lactose.
Yes.
Why?
Lactase deficiency.
Yes, perfect. Why? Because we have an enzyme, lactase enzyme. What's the function of? Okay, this enzyme is basically present at the brush border, right? The brush border of your small intestine. So this enzyme is basically present here. What's the function of this lactase enzyme? It's going to take lactose and it's going to break off lactose into your glucose plus
Galactose.
galactose. For example, if you do not have this enzyme, it means that the lactose cannot be broken down to glucose or galactose. It means lactose, okay, it's an osmotically active, agent, right? So it's going to pull off a lot of water with itself. As we cannot digest it, it's going to move forward, and as it is just pulling off a lot of water with itself. So the presenting feature would be abdominal distension, diarrhea, when after consumption of milk product, because milk product have abundance of lactose. Is that clear?
Yes.
Sir.
Perfect. So this deficiency of lactase enzyme can be due to two causes. It can be congenital, for example, individual who have congenital absence of this. Another cause, which is the most common one, is going to be your acquired, right, which develop in children basically, and we have temporary deficiency seen after small bowel infarction, right? Is that clear?
Yes.
Because lactase is highly susceptible to injury, right? So we have small bowel infection, by the way, right? So this infection can lead to injury of this enzyme, which in turn, okay, it's going to be a temporary deficiency. It can recover very soon, right? So next pathology which we are going to discuss is celiac disease, right? So most of you guys will be aware of this pathology, so I'll be just giving you a small, okay, celiac disease. You guys are going to be helping me with this disease. I'll be asking you some questions. Okay, it's an autoimmune damage of small bowel villi. Can I say that? Autoimmune
Yes.
damage to small bowel villi. Villi are very important for your absorption purposes. It's important for you absorbing your nutrients and things. In the first place, how do we get that autoimmune destruction? How do we get that autoimmune damage? So for that, though, for example, we have gluten. So what is gluten? You guys are going to be talking.
Gluten is
Wheat and barley.
Wheat and grains, right? Okay, so it's going to be the most pathogenic component of gluten is going to be gliadin, right?
Yes.
Okay.
Yes.
So individual with celiac disease, what happens if they consume wheat or grain product? Okay, normally the gliadin is going to be deaminated by an enzyme which is known as TTG. That is tissue transglutaminase, right? Okay. So an individual having celiac disease, what happens? This deaminated gliadin is going to be presented to your MHC class 2, right? And once they are presented to MHC class 2, what happens? It's going to generate a T cell response in these individuals, right? And this T cell response in turn can cause damage of your small bowel villi. Let me just repeat it again. Individual having celiac disease, if they consume gluten, right? What happens? We can have the gluten is going to be normally like the gliadin is the most pathogenic like component. Normally, TTG is going to trans deaminase it, and as a result of that, an individual celiac disease is going to have a presentation to MHC class 2, and as a result of that, an inflammatory response of T cells, which is going to be like the culprit here, right? This is going to cause destruction of your villi, which is going to cause problems. So if we have problems of villi, what would be the clinical presentation? The idea is very clear. You won't be having enough absorption, so we'll be having diarrhea, failure to thrive. We cannot absorb nutrients, right? Abdominal distension as well. Chronic diarrhea, bloating. Is that clear?
Yes.
Okay.
Yes, sir.
What else? We are also going to see like a small herpes-like vesicles that arise on the skin, which is known as dermatitis
Hepatiformis.
herpetiformis. And the idea is really clear. Why do we get that small vesicles? Normally, we know that we have dermal papillae, right? So in this pathology, what happens? We are going to have a lot of IgA as a result of that from the autoimmune inflammation. And IgA is going to be depositing, like it's going to be present at the tip of these dermal papillae, right? And this in turn can cause like local small kind of inflammation, which can lead to vesicles formation, right? So the vesicles are going to be similar as that of herpes vesicles. That's why we are going to name it as herpetiform. Dermatitis herpetiformis. Is that clear? Hello?
Yes, sir.
Perfect. So what would be the lab findings? Very important. You already know that. We are going to have IgA antibodies against either TTG, either gliadin, right? Which we discussed. Either it can be against entomycin. You know what is entomycin, right? Okay. An individual who are IgA deficient, right? We already know a condition IgA deficiency, right? This is basically due to deficiency of IgA. So in those individuals, we are going to look for IgG antibodies, right? So they're also useful for diagnosis. Is that clear? What else?
Doc, can you repeat, Doc?
Okay. From here or the lab findings?
Okay, like from the presentation.
Okay, so, clinical presentation. As we discussed that we are going to have like inflammatory cells that are basically destroying your villi, right? If the villi are being destroyed, what are going to be the clinical presentation? Abdominal distension, diarrhea. Why? You do not have villi, you cannot reabsorb food as well as water. Simple, right? So that's why we are going to have diarrhea. What else? Failure to thrive. As we are like, we cannot, this individual cannot reabsorb nutrients, so there will be problems with, like growth. Is that clear?
Yes.
What
Yes.
else we are going to see? Dermatitis herpetiformis. In these kind of individuals, those who are having celiac disease, they'll be having lesions on their skin or vesicles, herpes-like vesicles present on their skin, which are basically known as dermatitis herpetiformis. Simple. Why do we have that? These herpes-like vesicles? Okay, we have dermal papillae. If you guys remember that we have in the skin, we have a lot of, we have epidermis. Below the epidermis, we have dermis. We have papillae, which basically like consists of a blood supply and the blood vessels, right? So in these individuals, basically IgA is going to deposit at the tip of dermal papillae, and due to deposition of this IgA, it's going to cause formation of these vesicles, dermatitis herpetiformis. Is that clear?
Yes.
Okay. And how do we resolve all of these things? Just tell individual to avoid gluten. Give them gluten-free diet. Is that clear?
Mhm. Yes.
So we were discussing some lab findings. What would be the lab findings that are going to be very easy, right? We are going to have antibodies against tissue transglutaminase. Either we can have antibodies, okay, which antibody? IgA antibody, right? Either we can have IgA antibodies against gliadin, right? Gliadin, remember, this is going to be the pathogenic component of your gluten, gliadin, right? Okay. What else we are going to see? We can, okay, those individuals who are IgA, who have IgA deficiency, who do not have IgA. So in those individuals, we are going to look for IgG, antibodies against these components, right? It's good. In those individuals, the diagnostic antibodies are going to be IgG. Is that clear?
Okay.
What else? Yes.
Yes, doctor.
Okay.
We're following.
What else we are going to see? What else we are going to see? On duodenal biopsy, it's obvious. The villi, okay, normally villi are like that, right? So we will be having flattening of villi, right? Flattening of
Yes.
villi, because inflammation is going to damage your villi, right? We are going to have hyperplasia of the crypts. We know that if we just dive deep into histology, basically we have crypts, right? Remember the crypts, right? Okay.
Mhm.
So these crypts are going to become hyperplastic, right? So hyperplasia of the the crypts, and as well as we are going to have intraepithelial lymphocytes. The idea is really clear. Lymphocytes are going to be present within the intraepithelium, which is causing this damage of your villi. Is that clear?
Yes.
Yes.
Okay, perfect, right? So this was all about your celiac disease. Let's discuss our next pathology, that is going to be Whipple disease, right? So today, Dr. Mahin discussed it in a little bit, like she had discussion on that. Okay, so what is Whipple disease? You guys are going to, okay, just tell me a simple idea of, right, Whipple disease. What is Whipple disease?
Infection from Proforma whipple.
Okay, T. Whipple organism infection. If we have infection, what would happen? Where do we have which cells are the target cells of, okay, what are the target of this organism? Which cells are going to be the target?
Macrophages.
Filament cells.
Okay, macrophage. Can I say it's a kind of granuloma?
Mhm.
Yes.
Okay, perfect. So you're going to have macrophages. In those macrophages, you are going to have a ton of this organism T. whipple, right?
Mhm.
Proforma whipple, right? Okay. So these macrophages fill with T. whipple. Okay, what happens as a result of that? If you guys remember, we discussed the reabsorption of fats, right? Fatty acids. We discussed we have long chain, we have short chain. Short chain are directly taken into capillaries. The long chains are basically taken by your chylomicrons. Remember, the chylomicrons in turn are going to be reabsorbed in your lacteals, your lymphatics, right? You know that, right?
Yes, sir.
Okay, we did the physiology. Okay, so what happens? These granulomas filled with T. whipple, they'll just keep on growing here at the lacteal side, and in this way, it would compress the lacteals. If the lacteals get compressed with these granulomatous structures, now the lacteals cannot take in your chylomicrons. If the lacteals cannot take in your chylomicrons due to compression, right? What happens? We are going to have fat malabsorption. We are going to have steatorrhea, right? And with fat malabsorption, we are going to have problems of, there are some fat soluble vitamins, right? We can get a lot of problems. Is that clear?
Yes.
Yes, sir.
These granulomas are not only going to be present there, it's basically systemic tissue damage. They can also be present within the joints, causing problems there, giving you arthritis, inflammation, and in turn arthritis. They can be also present within the cardiac valves, giving you problems like if it can lead to stenosis, regurgitation. That can be present in the lymph nodes, even in the CNS. Is that clear? Let me just give you an overview. Let's just make it very simple. T. whipple filled with macrophages, a kind of granuloma, right? We know that. This granuloma can be present everywhere, even there in the lacteals, compressing them. Their compressed chylomicrons cannot enter your lacteals. You'll be having a long chain fatty acid malabsorption. It's a big problem. With that, we can have steatorrhea, we can have like problems with reabsorbing our fat soluble vitamins. They can also be present within the joints. It can give us arthritis, cardiac valves, and things like that. Is that clear? Hello?
Yes.
No?
Yes.
Perfect. Perfect. So let's discuss a really important topic, that is carcinoid tumor, right? So we'll be discussing the high-yield concepts of carcinoid tumor, right? What is your carcinoid tumor? We'll be discussing tumor in detail, but remember, most of the tumor you guys are going to see within the colon, within the within the stomach, within your oropharynx, within the esophagus, right? But the small bowel basically have, there are limited chances of getting tumor, right? But the only one tumor which is present within the small bowel is going to be carcinoid tumor. Remember that, malignant tumor, right? Is that clear?
Yes.
Okay, so we discussed that it's basically a malignant proliferation of your neuroendocrine cells. If you have malignant proliferation of neuroendocrine cells, we know that there'll be chromogranin positive. Remember from your pulmo sections, chromogranin positive, right?
Yes.
What would these tumors do? They'll just dump off a lot of serotonin, right? Is
Yes,
that
sir.
clear? Okay. So what happens? This serotonin basically is going to be like absorbed into your portal vein. It's going to be taken into your liver. In the liver, this serotonin is going to be converted into, yes, 5-HIAA. Simple, right? 5-HIAA. If you have this tumor, what happens? All of the serotonin, which is being dumped by these neuroendocrine cells, it will be reabsorbed within your portal veins, taken into your liver, and you have an enzyme that is monoamine oxidase, right? It's going to convert it into 5-HIAA. And it can simply, the 5-HIAA can simply be excreted in urine. But the problem arises when this tumor gets metastasized into the liver directly, right? As it's a malignant tumor, it can metastasize. If the tumor metastasizes into your liver, what happens now? This process which the liver does with the serotonin, this process converting it into 5-HIAA, this is going to be like skipped. This process is going to be skipped. Why? Because now the tumor primarily is present within the liver, giving you a lot of serotonin. So from the liver, a lot of serotonin is going to directly enter your systemic circulation, right? As we know, we have anastomosis, right? Followed by the systemic anastomosis. All of the serotonin is now going to be dumped into your systemic circulation, and it's going to cause problem. Once we have a lot of serotonin in the systemic circulation, now we call it as carcinoid syndrome, right? So what the serotonin is going to do, it's going to cause a lot of problems. It's going to cause bronchospasm, it's going to cause diarrhea, it's going to cause flushing of your skin, and it's basically triggered by any stress, right? So for example, if you have an individual, he consumes alcohol, or if he has some emotional stress, and the tumor has already been metastasized into the liver, and the process of converting it into 5-HIAA is skipped now, right? So now all of the serotonin is directly going to be dumped into your systemic vessels, and it's going to be causing this problem. Even it can cause carcinoid heart disease. What is carcinoid heart disease? A lot of exposure of this serotonin itself can cause valvular fibrosis of your tricuspid valve, right? Like for example, your heart, serotonin is going to enter into your right heart, then it's going to enter into your lungs, and then your left heart, right? So if you have a lot of serotonin, it can, like this tricuspid is going to encounter all of, presence of this serotonin, and it can get fibrosis there, right? Which in turn can lead to tricuspid regurgitation. But the left-sided walls are always unaffected. Why?
Because it get inactivated in the lung, the serotonin.
Yes, because within the lungs, again, we have this enzyme which is going to inactivate the serotonin, right? So the left-sided heart is like, again, it has M, okay, a monoamine oxidase. It would just, convert it into 5-HIAA, which do not cause this problem. So that's why the left side is going to be saved from the effects of serotonin. Is that clear?
Yes, sir.
Okay, let me just give you like entire overview of this topic, and this was basically our last topic. So tomorrow we are going to discuss the colon, its associated pathology, along with the liver pathology, right? So the class tomorrow is going to be a little bit big, and I also have another announcement to make. We will be joining with another tutor. He is there. He has got matched. He has incredible score. Like in step 2, he got 276, and step 3 he got 260. So I'm in conversation with him. He'll be also joining, helping you with your minors. I'll be like I'll be more like in the second phase, which is going to start within a couple of days. I'll be more on the revision side, and he's going to discuss the minors along with Dr. Ma. Is that clear?
Yeah.
And he have
Yes.
also got matched. So tomorrow we are going to introduce him. Although I'm just having some discussions with him. So hopefully we are expecting him to join our community, right? Okay, so that was a small announcement. Let's discuss serotonin syndrome again. Let me just give you an overview, and then we're going to finish off our class, right? So serotonin syndrome, you know, it's a malignant tumor of your small bowel, right? So what happens? It's going to dump off a lot of serotonin. Normally, we won't experience any problem because serotonin is going to enter into the liver, into 5-HIAA, excreted in urine, no problem. But if it gets metastasized into your liver, this process is skipped. Now serotonin is directly going to be dumped into your systemic circulation. This is going to cause problem. Which kind of problem? Bronchospasm, your diarrhea, flushing of skin, again carcinoid heart disease, but the left side is saved due to MAO present within your lungs, again converting into 5-HIAA, and no problems to the left side heart. Is that clear?
Yes, sir.
Yes.
Thank you so much, right? So,
Yes, sir.
hope so you guys enjoyed today's session, and see you. And I'll be sending you schedule in a while. And yesterday, basically, I had this discussion going on with Dr. Moaz, and he's going to soon join. That's why we didn't have class yesterday. So get prepared yourself for dedicated periods. Second phase, we're going to have a lot of classes, by the way. Right? I'm going to revise the entire course again, entire right from the cardiology. We'll be having like a lot of discussions over the previous systems which we discussed, and along with that we'll also be carrying out micro classes as well as like the tasks. So get prepared, get yourself prepared for that, right, along with the NBME. So this is going to be your accelerated phase for all individual, right?
Thank you so much, Dr. Ahmad.
Thank you. So hope so you guys enjoyed, and see you tomorrow. Bye bye.
Thank you. Bye.
Thank you.
Thanks, doctor.